Well, good evening, everyone. It's 7:30. If I could just get in the chat whether anyone can hear me, just do the quick sound check first of all. Amazing. Thank you very much. Well, good evening, everyone. So good turnout so far. Welcome along. Thanks for coming along on your Wednesday evening. Hopefully we've not dragged you away from putting up Christmas trees and decorations and all that good stuff. So very warm welcome. Thanks for bearing with us. We were away for a couple of weeks, lots going on. We had a surprise EQA visit and we had obviously we've got loads of work going on behind the scenes for our FREC 5 programme. So it was all just very, very busy. So we had a couple of weeks without the webinar, but we're going to get this finished off now. So we've got tonight and then the last in the series next week on the safe administration life-saving meds, the SARM medications update, which will follow this. So tonight is ILS, which I think is normally a very popular subject. We've got more people joining us, so I'm hoping the numbers will go up just a little bit. So very important and very popular subject. So just a kind of a note that tonight doesn't kind of replace your need as a FREC 4 or FREC 5 holder to do an annual face-to-face ILS update. So if you're in the market for one of those, we do have one coming up on the 12th of December, which you'd be more than welcome to join. It'd be lovely to have you along. This is just a kind of keep your head in the game type update for those of you that aren't out there practicing this type of stuff as often as you'd like to be. So my name's Dennis. I'm a paramedic practitioner by trade. I worked for London Ambulance Service for a great deal of my career, and the vast majority of that time on cars actually, and going to cardiac arrest. So hopefully I can answer any questions you've got this evening as they come up with regards to immediate life support. I now work in GP surgery, but still do bank shifts just to keep my hand in the game. And of course, I run STC Training Solutions, and we provide FREC training from our base near Aylesbury. So if anyone's interested in coming along and doing any of our fab courses, then do get in touch. We've done a special offer this evening because of the webinar. The webinar was tonight. Our Black Friday deal technically ended yesterday. We've extended it, so if anyone wants to make use of the 10% off all courses, Black Friday 21 is the discount code, then you have until midnight tonight. We've extended that by a day. And of course, there'll be a quiz tonight as well. We've got a quiz at the end. As those of you that have joined us before know that if you win the quiz, then you can get 10% off any course anyway. And actually that is valid for as long as you want it to be, so you don't have to book by midnight tonight. Rowie, thank you very much. Yes, it was great to see you. So folks, who have we got tonight? So we've got the Orkney guys. Welcome, nice to see you both. We've got Matt in Manchester. Rowie up in Cleethorpes, fab. Great to see you all. Lots of familiar faces tonight, and we're down in rather wet and windy Uxbridge. Actually, it's not been so nice this afternoon, but nothing in comparison to what the Northeast has been having, from what I understand. So right, it's just gone 7:30. So those of you that just joined us haven't missed anything. Welcome along. As I say, we do have some up and coming courses. So if you are in the market for a face-to-face ILS. Next one's on the 12th of December. There is still space on that. It's just 95 quid, or if you book by midnight tonight, only 85.50 with a 10% discount. FREC 3s and FREC 4s are selling fast, so we do want to get on one of those. We've only got space in the new year now, so limited space on our weekend FREC 3 course starting at the end of January. Still space on our Monday to Friday ones. FREC 4, only one space left on the weekend FREC 4 course, and our January FREC 4 is full. So if you want Monday to Friday, then February, we did add an extra SARM course in, which runs on the 18th and 19th of December, if anyone's interested in doing that, because our January one is full. So it would be, I think off the top of my head, March is the next one. So if you do want to do SARM with us, then do take a look at the 18th and 19th. As I say, 10% off you, but by midnight tonight on any of those courses. And of course, the winner of the quiz gets 10% off anyway. So, brilliant. So let's get going then with tonight's session. So it's intermediate life support, or immediate life support, interchangeable really. So what we're talking about tonight really is going up from basic life support. It's starting to think about some of the advanced airway management, starting to think about some of the decision-making processes, and starting to think about some of the kind of extra skills that you can bring as an ILS provider. So the series so far, those of you that are interested, if it's your first time along, we've done lots and lots of stuff as part of this series. It's all on our website and on YouTube. We've talked about CPD requirements, we've talked about ANP, we've talked about some pathophysiology, maternity care, patient assessment, paediatric assessment, sepsis, oxygen and Entonox guidelines, ECG basics, and here we are with ILS tonight, SARM next week. The idea of this series was really just to help those of you going through FREC 4 and beyond, really. So tonight we're going to talk about recognition of the peri-arrest patients. We're going to talk about stepwise airway management, initial cardiac arrest initial cardiac arrest management, manual defibrillation, mechanical ventilation. We're going to talk reversible causes, and we're also going to talk about post-resuscitation care, which is also kind of big area of loads and loads of research going on in there at the moment. We'd like you to be interactive. I'll keep an eye on the chat box, so throw any questions you've got as we go along in there for me. I'll do my best to answer them as we go. We're also going to use Mentimeter again tonight for the quizzes, and of course you can tweet us, call us, email us, etc. after the event if you do have any questions. So, recommend reading, as always, features ambulance care essentials and ambulance care practice core textbooks for the FREC program. The Research Council ILS book is very, very good, actually, and we do have it on sale, same price as the RC UK at £15 a copy. If you would like one of those, we can get those out to you. So, yeah, definitely a highly recommended book. So let's start with Mentimeter then. So grab your smartphones, go to menti.com and pop the code in at the top of your screen, 3513710. So go to menti.com, 3513710, and I want you to answer the question, what are the priorities when assessing patients? Nice broad question to start you off with. So menti.com, it will come up with a box where you put a code in. The code is 3513710. Excellent. Danger. Toe. Okay, safety, good. Let's have a few of you voting in there. There we go. Circulation, safety, danger, catastrophic hemorrhage, good. Good spot. Documents, yeah, potentially. Access, yeah, absolutely. Getting to the patients, I'm assuming we mean, that's good. Safety, the name, yeah, absolutely. Not knowing their name won't kill them though, but certainly not managing an airway, as we're seeing, is coming up. Most people voting for airway. Don't forget danger, of course, which a couple of you have mentioned there. So your safety is number one ultimately, isn't it? So as you approach the scene, no point you turning into a patient as well, but absolutely airway takes priority fundamentally. Catastrophic hemorrhage, if it's there, you're definitely going to deal with. Good. Perfect. I like it. I still don't know where the toe comes in, but here you go. Brilliant. So absolutely on the right lines there, folks. So your priorities when assessing patients definitely do revolve around your danger first and foremost, and of course this thing called the primary survey, don't we? So this in its most basic form is your airway, breathing, circulation, disability and exposure. Now fundamentally in ILS tonight all we're really going to be talking about is ABC. And in that order, you've got to maintain an airway. You've got to be able to kind of allow the patient to breathe or breathe for them, and we've got to be providing some level of circulation. Otherwise, nothing else is going to have any effect. It's the old thing. I think I've said it before in this series of air goes in and out, blood goes round and round, and really any variation on that is a problem. And that's about as in depth as you need to be in ILS. We've got to keep the air going in and out. We've got to keep the blood going round and round. In order for that to happen, you've got to have a clear airway for that air to go in and out. Disability and exposure, absolutely. D, we're going to start considering reversible causes. And E, of course, we're going to start to think about kind of secondary things that we haven't spotted, and also keeping the patient warm, which is really quite important. Oh, we're missing a slide there somewhere, but never mind. I've managed to delete something. It might pop out later at random. But of course, one of the things before that is assessing for patient level of response, and we had the AVPU scale as a slide missing with the AVPU scale on. AVPU, AVPU, alert, voice responsive, pain responsive, and unresponsive is the nice, quick and easy way assessing whether a patient is indeed, it can tell you fairly early on. Generally, peri-arrest patients aren't that alert. They tend to be lower down the VPU scale. And of course, the ones we're most concerned about tend to always be unresponsive when we arrive or shortly after. So I'm going to go back to NT again, and I've got another question, which is a little bit more in depth, and that is, what do we mean by the term peri-arrest? If I were to say to you, this patient's peri-arrest, what do I mean? Obviously, quite literally in Latin, it's around or close to arrest. There we go. There, pop some. So I think you get up to 3 answers. So menti.com, it's the same code, 3513710. Oh yeah, it changes swear words, so no point putting them in. Imminently about to die, immediately before arrest, immediately after. It's immediately before, generally, imminently about to die. Big sick, yeah, absolutely, it's that term. Expected to arrest before cardiac arrest. Hemodynamically unstable is a great word, brilliant, okay. Fantastic, okay, great. The others coming in. Unstable is the key, isn't it? Impending, clammy, yeah, that's good. That could be pre-cardiac arrest. Low cardiac output, that's good. So I'm going to ask you then, how do we measure that? So let's go across to the slides again. So recognition of peri-arrest, and most people, I think, if you ask them which observation is the most important, most people will come back to you and say, well, actually, blood pressure. If you're watching a blood pressure drop, actually that's your most useful sign of a peri-arrest patient. Now I do tend to agree, but it's not just the blood pressure in itself, it's this something called mean arterial pressure that we actually tend to consider more than just blood pressure on its own, and that's not something that's routinely taught. So blood pressure, yeah, absolutely, I'm sure you all know normal blood pressure ranges for an adult, I don't know, 120/80 is the textbook, isn't it? We can generally cope quite well to about 90 systolic. Below 90 systolic, we tend to have symptoms, whether that just be when we stand up, we feel a bit lightheaded, or whether we feel a bit lightheaded and dizzy at all times. Obviously, if our blood pressure is normally a bit higher than the textbook 120, we might get those symptoms a little bit higher than 90. But generally speaking, anything below 90 is going to be abnormal for an adult patient. So now that's useful, that's easy to spot, and we know that there are little cheats. Like if you lost your radial pulse, chances are blood pressure is below 90. But actually, we could do with knowing a little bit more detail. So we actually look at something called the mean arterial pressure, and that's, as it sounds, it's the average pressure within the arteries during the whole cardiac cycle. How do we calculate it? It's not the easiest thing in the world to calculate. Thankfully, things like LifePaks and Zoll, they calculate it for you. If you've ever wondered what that little number is next to the patient's blood pressure, you might see in the bottom left. I'm a LifePak born and bred. So LifePak 15, bottom left, where the blood pressure reading comes up, there's normally a little 2-digit number that comes next to it. I've heard people mistakenly think that's the heart rate. It's not, it's the mean arterial pressure. It calculates it for you. And it's the diastolic blood pressure plus a third of the pulse pressure. Now, pulse pressure is systolic blood pressure minus diastolic blood pressure. So it's the difference between the systolic and the diastolic. So we're going to add a third of that to our diastolic, and that gives you your mean arterial pressure. Not the easiest thing to do in the back of an ambulance at 2 in the morning, I grant you, but that's why our equipment does it for us. But it's something to bear in mind if anyone ever asks you about mean arterial pressure. Very, very useful number. So mean arterial pressure below 60 does actually indicate poor organ perfusion and actually a peri-arrest patient. So you can actually diagnose, you can actually define peri-arrest quite well. So yes, low blood pressure, fine. That's useful, and of course we look at trends. We don't just look at one number. We look at the trend. And as a few people said in the quiz there, just we're looking for the deteriorating unstable patients. So we're going to have to do serial observations. But yeah, absolutely. Mean arterial pressure, below 60. We're definitely starting to think a patient that's about to arrest. So brings us on to airway, really, doesn't it? So airway is one of the most important things we're going to consider tonight. So airway management. Let's go through a few things in a logical order. So As I said to you, if we're just breaking this down to ILS, which really is just ABC, that's all you're kind of focusing on, assuming that you're safe and the patient isn't responding. We need to have some awareness of what we're actually doing with the airway, don't we? Now, the 2 pinch points, I'm teaching you to suck eggs here. There's 2 pinch points in the airway. One is the tongue sitting on the hypopharynx, causing obstruction. And number 2 is where the 2 tubes meet within the larynx. You can get regurgitated stomach contents coming up the esophagus, pooling in this laryngeal area. And then, of course, when the patient takes breath in or the patient ventilated, some of that muck gets pushed down the trachea and into the lungs. Obviously, loads of complications of that, but most and foremost is anything that impairs the lungs' ability to perform gas exchange is obviously going to cause problems. So, and the whole point of managing the airway is to allow air to pass freely, or as freely as possible, in and out of the alveoli. So what can we do? So before you did your FREC 4 courses, those of you that have done it, the tongue sitting on the back of the hypopharynx, nice easy manual maneuvers, head tilt, chin lift, and jaw thrust. They get the tongue off. If you want to put something more permanent in, we've got the choice of oropharyngeal airways, nasopharyngeal airways. And then, of course, you went on and did your FREC 4 or equivalent, and then you were taught supraglottic airways, so your IGLs and laryngeal mask airways, the LMAs. And what do? They just travel a little bit further beyond the hypopharynx, and they sit over the glottis, over the entrance to the trachea, and they offer some protection against gastric regurgitation. Not perfect, not as good as an endotracheal tube, which of course is the gold standard. That's where that passes directly into the trachea and a cuff is inflated to prevent any kind of bypass. But that's effectively what airway management is all about, is getting those 2 pinch points covered. So let's have a look. The stepwise airway management, as I've just mentioned, you've got the option of not doing any airway management. Now, of course, in there's going to be situations or injury patterns where actually managing an airway is going to be really quite difficult. You're off duty, you've got no kit with you, you're walking around Tesco, somebody collapses and needs their airway managed or goes into cardiac arrest, the airway's covered in vomit, you've got no form of protection. What are you going to do? You're just going to do chest compressions only, aren't you? So there is always the option of not doing airway management, although that does tend to disappear very quickly as soon as you throw professional kit into the mix. So we're looking at manual maneuvers first and foremost. So if you want to open an occluded airway, then a good jaw thrust almost always gets you out of trouble. Back that up with an OP airway, and 9 times out of 10 you've gone as far as you need to go up this airway ladder. Nasopharyngeal airways are there as an option when OPs won't work or when OPs aren't enough on their own. I'm not a big fan of NP airways, but they do have their place. I often find they sometimes cause a few more problems than they create when you're putting a nasopharyngeal airway in, and you cause some significant bleeding within the back of the nasopharynx, and that just pulls down at the back of the throat, and you spend the rest of the resus just suctioning blood clots out. But maybe that's just more my experience than anything. But I don't find them overly useful in practice. I find a good jaw thrust and an OP airway sorts things out a lot of the time. Supraglottic airways, of course, we'll talk about IGLs and LMAs tonight. They're very, very good. They do work surprisingly well. Of course, they're not perfect protection against stomach contents entering the trachea, but they're better than obviously nothing, which would be an OP airway. They're definitely better in the vomiting patient, but still not perfect. The endotracheal tube is really the only thing that can kind of protect completely against vomiting. Then, of course, you've got the transtracheal jet insufflation, which is the needle crike, and surgical airways for the critical care paramedics that can place tubes directly through the neck in these situations which we call can't intubate, can't ventilate patients that we just can't get air in and out of their lungs. That's the last ditch effort. The manual maneuvers, I've talked about head tilt, chin lift here on the side. One of the big downsides with that is, of course, in patients with suspected cervical spine fractures, we've got to be very, very careful doing those kind of large maneuvers which involve lots of relative movement, head versus neck. So, of course, we tend to default to this jaw thrust. So we rest the meaty bits of our thumbs onto their cheekbones. We use our spare fingers just to bring the jaw forward, and maybe our thumbs, if they're free, just to pop the mouth open, because there's a tendency for the mouth to close as we bring the jaw forward. That's a good jaw thrust, well practiced. If you come along on our courses, it's something we'll make you practice until you're good at it. A good jaw thrust will get you out of trouble. Okay, it's useful in almost every situation, whether it be just unconscious, fitting, cardiac arrest, anything like that. A good jaw thrust combined with a bag valve mask will almost always get you a good level of ventilation. What if we need more? We've got these things called guidal airways or oropharyngeal OPAs, the oropharyngeal airways. We're talking about adults predominantly tonight. So of course we insert OP airways backwards in the adult population, don't we? So we slide them along the palate until we meet resistance, and then we twizzle them through 180 degrees as they drop in nicely behind the tongue. And the idea is that the kind of the plastic lumen of the tube sits comfortably behind the tongue. It brings it off the hypopharynx and allows air to pass behind it. It effectively does the same job as a jaw thrust. Sometimes you need to put a little bit of a jaw thrust on just to get the OP airway to sit comfortably behind the tongue, particularly if the tongue is sitting at the back of the throat. You don't want to push it any further in. But almost, again, as I said to you just a second ago, almost always this in combination with a jaw thrust and a BVM. Very rarely need to go any higher. Generally, we only go higher. We only go up to igels because of a requirement for ALS, or because of transport, or you know, the patient vomits or something along those lines. But generally, at any time, I tend to escalate an airway from that. Good. So we have the other option of the nasopharyngeal airways, which go up the nose. Oh, I should flick back with the OPs. Just a quick reminder on how you measure them size-wise. So we pop effectively we're going to overlay the OP airway, as you can see at this picture furthest on the right. So place the OP airway against the patient's cheek with the flange, kind of level with the teeth. And what we're looking for is that the end meets the angle of the jaw. If it goes too far past, we run the risk of starting to stimulate a bit of a gag reflex. If the OP airway is too small, it has the tendency to push the tongue against the back wall of the throat, which of course is what we're trying to avoid. So size does matter. We do need to get the right size, and absolutely, just so in adult patients, inserting it to 180 degrees. In child patients, if you go on and do a PILS course, or if your company allow you to place OP airways in children, we just use a tongue depressor and we place the OP airway in the right way around. We don't scrape it along the palate, because obviously in younger children their soft palates aren't fully formed, and you run the risk of causing significant airway trauma. So the nasopharyngeal airway for when the OP doesn't work, or when there's a reason that you can't put the OP airway in. So generally speaking, we only use size 6 and 7, the bottom two. I've never seen a size 8 or a 9 on an ambulance. I dread to think the size of the person's nose that would need to go into. But generally speaking, we generally only see size 6 and 7 on the ambulances. Now there's a rather lovely rhyme to remember that. So it's 6 for chicks and 7 for dicks, is the way we were taught. That's certainly everybody remembers a rude rhyme, don't they? So generally speaking, size 6 for female patients, these are adults, and size 7 for male patients. But fundamentally, we're going to put the largest one we can in. But again, normally the largest you have is a 7 anyway. Remember to lubricate them first. Don't need to lubricate an OP airway, but you do need to lubricate an NP. Otherwise, you'll cause trauma, and it just won't slide in. NP airways, we've got to be very careful. If you meet significant resistance, don't keep going. It could be a nasal polyp or something like that, and boy do they bleed if you rupture them. We've also got to be very careful in base of skull fractures. So patients that have fallen a significant distance, either landing on their head or landing on their feet. So that's what we term axial loading. There is a very high risk of base of skull fracture. If you suspect base of skull fracture, then please don't use the NP airways. And we're not allowed to use them in children. So they do make them in child sizes. I'm not entirely sure why, because I've never, in any of my kind of roles, I've never seen pediatric NP airways being used. Very rarely a need to in children, to be fair. Good. So after OP and NP airway, we're looking then at the supraglottic airway. So if you are ILS trained, obviously this will be part of your armory. So the good old iGel, I've shown you all the sizes there again. Unless you technically go on to do a PILS course, pediatric ILS course, then it depends on your company whether you're allowed to place iGels in children, but effectively it's exactly the same. So we are going to lubricate around the edge. You've got that nice soft rubber kind of molding at the end, which melts slightly as it goes into the patient's body, as the patient's body heat warms it up, and it forms a nice seal over the entrance to the trachea. As you can see, the kind of pointy bit at the end slides down slightly into the esophagus and offers some protection against gastric regurgitation. And of course, the opening of the eye gel itself faces outwards into the trachea itself. So in theory, any air that goes in the top is going to end up in the trachea. Provided the trachea and upper airways are clear, then of course that's going to result in chest rise, which is good. And as I say, the longer it sits in the patient, the better the seal forms. The benefits of having an SGA, as I've said, is kind of transport. So obviously we can connect to a ventilator, we can connect directly to a bag valve mask. We have the option of securing these quite well so that we know the airway is relatively patent. In a non-vomiting patient, they're about as good as you need. Obviously the next step up is endotracheal intubation, which is your paramedics. But of course there's not always a need to go up to that. The option, so the other alternative to the eye gel is something called the LMA, the laryngeal mask airway. Now they are a bit of a dye breed. I haven't seen one in practice for a little while now. But effectively they're the same thing. They sit in the same place as the eye gel. The only thing is they're a bit more faffy because you have to inflate that cuff. So you place the cuff in unventilated. They tend to go in past the tongue a lot easier than eye gel, I'll say that. And once they're in position, they form a very good seal. They're very useful when you have a ventilator attached. They tend to work slightly better with a ventilator from experience. But of course, you do need a 20 ml syringe and an extra pair of hands just to kind of get it into its sweet spot and inflate the cuff so that you form a nice seal. But again, they work in exactly the same way as the eye gel. A lot cheaper, which is probably why you do still see them around. They're £3 something versus 15 quid for an eye gel. So, but then again, for how often for your own kit are you going to use an eye gel? Hopefully not too often. And just for those of you that aren't aware of what endotracheal intubation is, that's what it is. The tube passes actually through the vocal cords and into the trachea itself. It's the main windpipe. We inflate a cuff to hold it there and to form a seal. And basically we know for 100% anything that goes in this end is definitely going to end up in the upper airways. Again, it's paramedic skill, not something that's taught to any non-registrants in the UK, as far as I'm aware. So, and I'm sure we'll be aware increasingly that's a skill that you're not seeing quite so much on the road anymore, which is a shame because it's a very, very useful skill. So, you know, a lot of emphasis on airway, really, isn't there? If anyone's got any questions, just throw them in the chat as we go. We've got the quizzes at the end tonight. So, but hopefully that's all making sense so far. It's a stepwise process. We don't just rush in for eye gels every time. Not every time. I say sometimes we do, but there's generally reasons for that. We either think, okay, we're definitely going to be moving, or there's vomiting going on, or something along those lines. But generally speaking, jaw thrust, OP, NP. And then we consider eye gels if things still aren't working. So your initial arrest management, obviously thinking back to the chain of survival, which hopefully you've all been taught at some stage, early recognition of cardiac arrest really is key. Early recognition, getting on good quality CPR, good quality early defibrillation, and good post-resuscitation care are the 4 stages. And of course, you know, number one is recognizing this unresponsive, not breathing normally casualty. And I think when we're new to the industry, when we're first presented with a patient that's just arrested and they're agonal breathing, or they might still be having a bit of a hypoxic seizure or some non-purposeful movement, it can be really quite difficult to recognize cardiac arrest. I think a lot of people feel that. But if in doubt, you know, good, 10-second feel for breathing. If you don't think it's regular, if you can't feel a pulse, then absolutely crack on with ILS. And of course, the initial thing is CPR at 32. If you have a defib there, then priority really should be getting the defib on, particularly in adults, where there's much greater chance of a shockable cardiac arrest rhythm. Calling your resuscitation team, that's obviously aimed at the hospital, but of course out of hospital we're going to call for backup, aren't we, particularly if control don't know that it's a cardiac arrest. And then one of the very early stages we're going to have to do, you guys that have done ILS will be taught manual rhythm recognition and manual defibrillation. We need to be identifying as quickly as we can what rhythm what cardiac arrest rhythm the patient is in, and deciding whether or not they need a shock. So early CPR, so 32. If there's two or more of you, one of you does CPR, one of you gets the defib pads on, that takes priority over doing BVM, kind of setup and initial ventilation in an adult anyway. If there's only one of you, get the defib on. Whilst the defib's doing its thing, then you can get your bag valve mask out and then start to do that way. But absolutely, kind of joint priority is getting on that CPR and getting the defib up and running. If it's shockable, obviously we're going to deliver a shock, and then we're going to do good quality 32 CPR for 2 minutes, returning to assess the rhythm as close as possible to 2 minutes. In an adult 32 situation, that's 5 rounds of CPR. So ideally, the person on the chest should be keeping track of how many rounds of CPR they've done and shouting that out loud. At the end of the 5th round, we should be looking at the screen and deciding what we're going to do, shockable or non-shockable. If it's non-shockable, of course, we don't shock, we just carry on with CPR. If you've got a PEA or a VT, we do need to be just doing a quick pulse check before we decide what we're doing next. So these are the rhythms. So we've got asystole there, top left, which is your flat line. I think most people are happy with that, and PEA, which is your other non-shockable rhythm. PEA effectively is the remaining one, isn't it? So if it's not one of the other 3, it's got to be PEA. So it's any kind of coordinated electrical activity, anything that's recognizable as a complex, but it doesn't produce any pulse. So so it used to be called EMD, electromechanical disassociation. So, and I think that sums it up quite well. So the electrics and the mechanics of the heart are disassociated, now called PEA, which says the same thing basically. It's pulseless electrical activity. The 2 friends at the top there, VF and pulseless VT. So obviously VT can have a pulse. They generally tend to be quite unstable, so they may not have a pulse for long, but VT itself, we do check for a pulse. The same with PEA, because the only thing that makes PEA is the pulseless bit. Good. VF, obviously no need to feel for a pulse, it's never going to have a pulse, just shock it. And of course asystole, there's absolutely nothing to be done electrically there. The whole idea of the defibrillator is to defibrillate. Ventricular fibrillation is going to stop that, put it to flatline in the hope that the heart's underlying pacemaker, the SA node, takes over. That's the idea, isn't it? There's nothing to do in asystole, so just good quality CPR and see whether you can get some PEA going on. But unfortunately, the outcomes aren't brilliant from asystole. I've put the drug protocol there just in case any of you are out there working with ALS providers. This is quite useful to know what other paramedics are going to be wanting to do. So for non-shockable rhythms, we just give adrenaline. It's 1 milligram IV every 3 to 5 minutes, and we start that regime as soon as we can get access. So if you see me turn up to a cardiac arrest and things are already going quite well, I've not got any major airway concerns, the first thing I'm going to be doing, particularly in a non-shockable rhythm, is getting some good IV access. And getting that adrenaline protocol going. So every 3 to 5 minutes. So generally we do it every second round. So brilliant. So the shockable protocol for VF or pulseless VT is obviously most important thing is getting that shock in every 2 minutes. Once they've had 3 shocks, we can then give them 1 milligram IV adrenaline exactly in the same way. That's every 3 to 5 minutes. Practice I do it every 2 shocks, so that's every 4 minutes. Amiodarone after the 3rd shot, we give amiodarone stat dose of 300 milligrams, and then after the 5th shock, some local variations on this, but after the 5th shock, I tend to give 150 milligram half dose stat dose after the 5th. So that does vary somewhat across the country, and of course that's your paramedics' responsibility to. But you never know. Sometimes when things are all going a bit wrong, I'll delegate the kind of the drug regime to somebody competent. So you may well be asked in those situations just to assist with that. So fab. So one of the other things we talk about in our ILS courses is these bits of kit, these mechanical ventilators. So I don't know those of you that are out and about, how many of you are actually using these, how often you get the chance to use them. They're fitted to a lot of ambulances up and down the country. I think they probably scare a few people when they look at all the knobs and dials and they forget what to do with them. They're not labelled in the most user-friendly way. Some of the dials aren't particularly clear. But very, very useful. They're your friend. In a post-ROSC situation after cardiac arrest, we've got a patient that's in relative, got cardiac output, but they're not breathing. This just frees up that extra pair of hands and does a far better job than humans normally do. We have a tendency when we're ventilating patients by BVM to be a bit quick and a bit heavy-handed with the squeezing. With the ventilator, it's going to give you what you dial into it, and ultimately there's a fairly easy way of deciding what settings to put things on as well. So we're going to go through that for those of you that haven't had a chance to use it very much. As I say, come and do your ILS with us. We'll go through this in the classroom. You get to play with the with the ventilators on our resus mannequins. So the ventilation, so I tend to start top right. So I tend to set the ventilation frequency at 12 a minute. So I always start a ventilator at 12 and 500. So you've got the tidal volume down the bottom here. Absolutely right, Paul, you do need CO2 coming onto that. So you'll see there's a tidal volume down at the bottom there. Okay, so the book says you should have that at 7 mil per kilo. I can't do maths that quickly in stressful situations. So the starting is 500. So we start at 12 and 500, 12 breaths per minute, 500 mil per breath. Once you've got the brain capacity, by all means, set it to 7 mil per kilo, but start yourself at 500. It's nice and easy. You're not going to go far wrong. I set the air mix. So on the Parapack 200D, which is shown in the picture here, the one that most ambulance services use, you have the choice of 100% or 45%. This is where the labeling starts getting a bit weird. So air mix basically means it mixes the oxygen with air. No air mix means it doesn't mix the oxygen with air. So no air mix is 100%, air mix is 45. I really wish they would just relabel them as half and full or something, just so we know how much oxygen we're giving the patient a bit more clearly. This is the only one that is really relevant for safety at this point, and that is the maximum airway pressure. That's the pressure release valve. Set that at 40 for an adult. There's never really any reason to change that. So unless you're really confident with what you're doing with a ventilator, don't change that. So 40 centimeters of water is the maximum pressure there. Then we have the on-off switch. Effectively, demand is off and CMV demand is on. CMV means continuous mandatory ventilation. So why they can't just label that on and off? In theory, in demand mode, well, in theory, in practice, in demand mode, when the patient takes a breath, it will deliver them with 100 or 45% oxygen, whatever's been set, but it won't make them breathe at any set rate. In CMV, it doesn't matter how often the patient breathes. It will kind of average it out. It will make sure the patient kind of breathes at least 12 times a minute. And then here we go. This is what Paul's just gone on to there. Is you do need a CO2 monitor technically if you're going to use a ventilator. I would say if you're going to use a ventilator without CO2, I mean, there shouldn't be a reason why you would. Then I just wouldn't adjust the settings really. I'd just leave it at 12 and 500 and 100% oxygen. I wouldn't bother doing anything different with it. You're fairly safe then, because that's what you're going to do with a bag valve mask at the end of the day. If you've got CO2, and absolutely should do, if you have a ventilator, you should have a machine capable of reading CO2. We want to aim for 4.6 to 6. That's the normal adult range. So patients out of ROSC generally come out quite high. So you might see 10, 11, 12, something like that. So what we want to do is ventilate maybe a little bit quicker. So we're going to use the CO2 to set our frequency. Okay. The tidal volume, once we've set it at 7 mil per kilo, we don't change that. The ventilation frequency is going to be the only thing. Once the ventilator is set up and on, that's the only knob you're going to play with. All right. No puns there. Okay. So the ventilation frequency is the only one you're going to touch once it's up and running. So if you've got a CO2 high, you could increase the frequency slightly until it comes back down to 4.6 to 6, but always just return it to 12. 12 is normally going to sort you out. Okay. I would be cautious about turning it down. If you've got a low CO2, it means there's something wrong. It's not. The patients that have just come out of cardiac arrest don't have low CO2. If their CO2 is really low, there's either a blockage somewhere or the patient is rearrested. So don't be slowing the machine down. That's not a normal thing to do. I tend to tell my students never really to go over 25, but I find anything over 20 just sounds a bit uncomfortable. It sounds a bit too fast. So use 15 or 20 in those times when the patient's CO2 is really high. But generally speaking, you should be able to get it back down to 12. 12 and 7 mil per kilo, fairly soon after ROSC, if all things are going well. That's what you really need to know about ventilators. They're not scary. Obviously, you've got the patient circuit that plugs into the big silver kind of connector that you can see on the side of the screen. You've got to connect it to oxygen. Obviously, these things won't work without oxygen because they're pressure driven. The fancy Draeger ones that are electronic will run on just room air, but these won't. So. Good. So don't be scared of them. Do use them. They are your friends. Post cardiac arrest. They are definitely something to be used. So this brings us on to reversible causes, which we mentioned at the beginning. So during, as ILS providers, these are things that you should be thinking about kind of during the cardiac arrest. So I know we've got kind of out of order, haven't we? I should swap those slides in. The reversible causes are things that could have caused a cardiac arrest. There are 8 big kind of subjects that everybody should know. They're known as the H's and T's. Let's start with H and T. Hyperkalemia. Just think of that one as that's the only one that we can't routinely measure out of hospital. I know there is some kind of focus, point of care blood testing going on and trialing around the country with the CCP. So some ambulance trusts can measure potassium and BBG, ABG at the side of the road, but it's not widespread yet. So we're generally not measuring the hyperkalemia. What we're actually doing there is hypo or hypoglycemia, because we're looking at other metabolic causes, metabolic being generally stomach related. So have a think about low or high blood sugars as a cause of cardiac arrest. So hypoxia, nice and easy, is the one that we generally always think of first. Hypoxia, as long as we've got a good airway and we are actually ventilating the patient. Now, you know you're ventilating from your CO2. A good box waveform on your CO2 is with a rate, a measurement of over 1.5 in cardiac arrest is good. That means you are doing good chest compression and you are ventilating the patient effectively. We should be giving 100% oxygen during a resuscitation attempt and initially post-ROSC. There is a lot of guidance coming out now from the Research Council and all the studies that are going on that actually over-oxygenation post-ROSC can be a problem. So we should be making it a relatively high priority to get an accurate saturations after cardiac arrest. As soon as we have established that the patient's sats are kind of in that 94 to 98 range, we can turn the oxygen down. That's why the ventilators have these options to ventilate at less than 100%. So we should use those depending on the local policies. A lot of local policies still say just leave, if they're on the ventilator, leave them on 100%. So just follow your local guidance. Hypovolemia, again, should be obvious to you, but you do have to consider the internal bleeds that might not be so obvious, or the dehydration, the kind of more chronic problems that led up to cardiac arrest. Metabolic, as I say, thinking about blood glucose. Hypothermia, thinking about the body's temperature. So with hypothermia, the question is, are they hypothermic because they're dead, or are they dead because they're hypothermic? Okay, if it's the former, you can probably stop. Okay, if they're hypothermic because they're dead, they're dead. You can't bring them back. If they are dead because they are hypothermic, then you've got this really annoying phrase that always comes up of that you're not cold and dead until you're warm and dead. What that basically means is that the resuscitative effort should be continued until the patient can be artificially warmed to kind of normal body temperature, just in case they are in what's called a low flow state, where there is some underlying cardiac activity that isn't palpable as a pulse, and actually they're just in a very deep peri-arrest state, almost like a hibernation state. So patients that are dead because they're hypothermic, or where that's the theory, they should be taken to hospital. They should be warmed up, and then only when they reach normal body temperature do we pronounce them deceased. So, but of course, it's more often than not they're cold because they're dead. So in which case that's the condition unequivocally associated with death, isn't it? Almost always. So. Good. So then clear as mud, hopefully. So thrombosis, don't forget about PE. Everybody thinks about MI, don't they? That's probably the most common cause of adult FREC anywhere in the UK. Is a nice big MI. But of course, don't forget about pulmonary embolism. And we should be thinking about those. In particularly younger patients that have gone into cardiac arrest, young females in arrest. It sometimes turns out to be a PE. So something to think about. Men get PEs as well, but it seems to be more prevalent in women. So definitely have a think about that as an alternative cause. Again, both of those are reversible causes. The reason I should have clarified. The reason we're looking at these reversible causes is this might be a reason to take your patient in cardiac arrest to hospital. Of course, that's not something we undertake lightly. Generally speaking, we provide much better care if we don't move. We bring the ALS provider to the patient, and we do good ACLS at wherever the patient collapsed. But of course, there are going to be situations that we can't fix. So these are situations where you might want to take your patient to hospital in cardiac arrest. Tension pneumothorax and cardiac tamponade, of course, are your two trauma ones generally. Now, tension pneumothorax can occur in asthma and COPD exacerbation, but it's generally thought of as being a thoracic trauma, as with cardiac tamponade. Cardiac tamponade, of course, being the collection of blood or fluid around the pericardial kind of cavity. And toxins, everyone thinks heroin, don't they? But there are loads of things that can cause cardiac arrest if taken in overdose. Tricyclic antidepressants, like amitriptyline, are horrible. You know, the diazepams, the benzos, all those types of things. They're not reversible with naloxone, but they can still certainly put a patient into cardiac arrest. Of course, everyone thinks naloxone. Everyone thinks when they talk about toxins, they're looking for you know, needles hanging out the arms and tourniquets still on and things like that. But actually, the last time I gave naloxone was to a little old lady who'd just been changed from cocodamol to tramadol by her GP and misunderstood the dosing. And instead of taking kind of 8 cocodamol tablets through the day, and she was only on a low dose, she took 8 tramadol tablets at 800 milligrams of tramadol, up from a normal daily dose of about 60 milligrams of codeine. So that was the last naloxone dose I gave. She was in fairly deep respiratory depression. So we're not always thinking about heroin addicts, stereotypical heroin addicts in a dark alleyway somewhere with a needle sticking out their arm. It doesn't always happen that way, but certainly something to think about. And it's not just heroin to think about there, or opiates. Good. So post-resuscitative care then. So most important thing post-ROSC nowadays is looking at CO2. Really, it's trying to keep the patient's CO2 within the normal range. If their CO2 is deranged, we should be using our ventilator or BVM to get that CO2 back into that 4.6 to 6. Okay, so hypercapnia, as it's called, high levels of carbon dioxide in the bloodstream cause a relative acidosis. The body does not like being acidotic. It causes loads of organ damage and loads of brain damage. So we're seeing a definite link between early recognition of hypercapnia and early correction of that hypercapnia using, you know, good ventilator technique with much better neurological outcomes in patients. The same is also becoming true of over-oxygenation, leaving your patients on 100% oxygen for too long. But as I say, the guidelines for that are still a little bit behind kind of the hypercapnia stuff. So you'll see now in a lot of trusts early recognition of getting end-tidal CO2 on. If you haven't had it on in the cardiac arrest, which is really, we need to get it on in this post-ROSC phase and get that patient's CO2 down to a normal range as quickly as you can and hold it there. Apart from anything else, is one of the big triggers, as I said, that your patient has rearrested. If your CO2 drops off all of a sudden, has your patient rearrested or has the monitor come, you know, detached? So oxygen, if your local guidelines allow you to do so, we can start to titrate oxygen down after you know, stable ROSC has been achieved. And we should be looking to get a full set of observations, including a 12-lead ECG. Now, bear in mind those early ECGs, ischemic, you know, hearts that have just been in cardiac arrest, they've just been kind of jump started. They don't give normal ECGs. You don't expect your first ECG to make a lot of sense. It's going to be a bit of gobbledygook. But fairly soon after, you should be able to start picking out those signs of MI, and that's effectively what we're looking for, isn't it? Starting that early recognition that of the factor that caused the cardiac arrest. Looking at blood pressure monitoring, we really want to get a systolic blood pressure above 100, don't we? But and paramedics can use you know, some medication to help with that, whether it's a rate problem or a pressure problem. We can give adrenaline, or we can give atropine. And fluids, of course, but of course you want to be careful not to fill them up too much. So and then temperature control. So this is where E was quite important on the primary survey. Again, was to think about keeping those patients as warm as possible. The colder they get, the more problems they have, the more kind of acidosis they get, lactic acidosis, and loads of other issues going on. So then we've got to start thinking about what we're actually going to do with our patients. So if we think that the patient has a cardiac arrest because of a cardiac cause, i.e. a STEMI, basically, and if we can prove that with the ECG, brilliant, off we go to the cath lab, not a problem. If we're not so sure, it's still worth a discussion with CCU, isn't it? Generally, most adult patients that present in a shockable rhythm are going to have an underlying kind of cardiac cause to their arrest, and they almost certainly are going to end up underneath the cardiologist. In London, we were doing a trial before COVID. It'd be really interesting to get that up and running again and see the results. We were doing a trial before COVID of taking all patients presented in a shockable rhythm to the cath lab, regardless of their post-ROSC ECG, and actually that, I think had some promising results. So I think that's probably going to be informing some future policy, which will be good. But again, it'll be good to get that one back up and running. And then, of course, we've got the, well, we don't think it was a cardiac cause and there's nothing on the ECG. Then, of course, you just get local A&E for you know, most of these patients are going to end up on ITU. So. And apart from that, it's really just getting good observations, making sure somebody has, for want of a better phrase, a finger on the pulse. One of the most embarrassing things is realizing the patient's rearrested, and actually you were a little bit slow to realize that. So making sure somebody is monitoring your patient. These patients, you probably haven't fixed the initial problem, particularly with the cardiac guys. So if they've had a massive MI and a VF arrest, you've shot them a couple of times, given them some good CPR, they've come back. Guess what? You probably haven't fixed the blockage. They could arrest at any time, and in fact they will. They'll arrest at the most annoying time generally, but that's by the by. So make sure somebody is keeping an eye on it. That's somebody's job. Probably the person that's at the airway end, either watching the ventilator or squeezing the bag. They've got to keep a finger on the pulse, keep checking that carotid, make sure they haven't lost output. If they see a shockable rhythm, just get on and shock it. And keeping an eye on those observations, because ultimately peri-arrest is not just before the cardiac arrest. Peri-arrest is when they've had a ROSC and they're about to re-arrest again, isn't it? So recognizing that peri-arrest patient is key. And of course, mean arterial pressure, your machines are going to be giving you that, but just a low and decreasing systolic blood pressure is always a warning sign, particularly then if you start to get bradycardia and unstable cardiac rhythms, loads of PVCs being thrown off, that type of stuff. Get ready for another shock. So hopefully that has been useful for you this evening, guys. We're going to go into the quiz. I've got 10 questions for you. It's against the clock, so you've got 15 seconds to answer each question. Those that get it right will win points. Those that answer it correctly and in the quickest amount of time will get the most points. At the end of the 10 question, the person with the most points gets 10% off any course of their choosing. So I'll pop it up on the screen now for you, Jenny. The code is going to be the same. So if I flick it forward now, you should see, there you go. Brilliant. Okay, lots of people have joined already. Fantastic. So 3513710. Join the quiz. I do ask, if you haven't already, just use your real name just so we can reconcile who's won at the end of it. I've got a list scribbled down next to me of people that have won that haven't claimed their 10% yet. So, but somebody win twice. Doesn't mean they get 20% off. So I'll just put that out. Does anyone else want to join? So go to menti.com 3513710. Once I start the quiz, you can't join, I'm told. So if you want to join, get on there now. Even if you don't want 10% off, it's just good fun. Test your knowledge. Fine, just give it a few seconds longer. There we go. We're hovering about 16. Anyone else? Otherwise, we're going to get going. Oh, the rabbit keeps disappearing. Right, let's get going while the rabbit's there. Okay. So, looking at your phones, answer quickly. Which of the following is a contraindication for nasopharyngeal airways? Fantastic. Excellent. Most of you getting that right. So nasopharyngeal airways, not affected by trismus, not affected by seizures, not really affected by spinal injury. Just got to be careful with not doing too much head movement. Base of skull fracture, because the bones between the top of the nasopharynx and the brain, effectively, if they're broken, you run the risk of penetrating the brain, and they tend not to like that. So 11 of you got that right. Very well done. So let's see who answered that the quickest. Chris Rea. Is it Chris Rea? Are you driving home for Christmas? You shouldn't be driving and using your phone if you are. So fantastic. Well done, Chris. Okay, next question. Looking at your phones. What's the compression ventilation ratio for an adult? Nice easy one. Good, perfect. Some people getting tricked out there. 15-2 for children if you're a healthcare professional, 30-1 and 15-1 don't exist. So 30-2, fantastic, very well done. Let's see who got that one. Nice, straightforward one there. It's a lot more difficult when you've only got 20 seconds, isn't it? So still going for it. Matt was the fastest there. Chris, Matt and Brian, fantastic. Well done. Question 3. Which of the following takes priority in a peri-arrest patient? Everyone's voted. Ooh, interesting. A little bit of a trick question there, isn't it? So chest compressions, whether peri-arrested, not quite arrested. Observations are important, but if the airway needs managing, that's going to take care. Yeah, calling for a paramedic is important, but the patient's going to die without airway management. They're not necessarily going to die without a paramedic. Okay, so definitely one of those things. Actually, very rarely are they going to just die because the paramedic isn't there. Good stuff. Well done. Let's see who got that right. Good. Same old faces. Perfect. Brian. Brian's taking the lead again. Come on, Brian. Gotta let somebody else win. Excellent. Well done. Question 4. What's the normal end tidal CO2 range for an adult? Brilliant. Everyone's voted. Good. Yeah. 60 to 100, just to trick you. Very good. 12 to 20. So it was 4.6 to 6. Very well done. Fantastic. 12 of you getting that right. Let's see who answered it in the quickest time. Who's fastest there? Raya again. Brilliant. I don't actually know your surname, Chris, but you are forever now going to be known as Chris Raya. Excellent. So, as it is December, obviously. Question 5. It's the starting tidal volume for an adult. This is on your ventilator. Where are you going to start? Good, well remembered. Excellent. So 7 mil per kilo is what the textbook says. So 500 mil is a good starting point if you're not sure, if you don't know the patient's weight. So for a typical adult, 500 mil at 12 breaths a minute is absolutely fine to go for. I wouldn't necessarily go as high as 700 mil. That's the right setting for a 100 kilo adult. But generally speaking, 500 is a good starting point. So very well done. Excellent. You got that right then. Chris, steaming ahead. Brilliant, well done. Excellent, next question. ROSC patient has an end tidal carbon dioxide of 12. What would you do with the ventilator? Decrease frequency, decrease tidal volume, increase frequency, or set it to 45% inspired oxygen? Good, well done. Most of you got that right. CO2 is high, you've got to overventilate, haven't you? It's basics of gas exchange. If this isn't making sense, have a look at some of the respiratory pathophysiology and physiology. If CO2 is high in the body, you've got to ventilate, you've got to blow it off. Okay, turn the ventilator up. And as I say, don't be tempted to go much above 20 because you'll find that CO2 crashes down quicker and it can be quite damaging to the patient to be hypocapnic as well in those early stages of ROSC. Good. Perfect. We've got that right. Chris is steaming home for Christmas. Excellent. Well done. Perfect. So Matt was fastest on that one. Question 7. How often should a post-ROSC patient be manually ventilated? So if you don't have a ventilator, how often are you going to use your BVM? Good, well remembered. Didn't cover it tonight, did I? Every 6 seconds. Once every 6 seconds gives you 10 breaths a minute. It's not a bad starting point. Okay. So fantastic. Let's see who got that. You got that right. So that's when you're using the bag valve mask. Obviously, you've got the ventilator, you just sit at 12, but too hard to do 12 by hand. Mine was pretty quick there. Emma was fastest there. Very well done. Perfect. There's a lot of similar names popping up at the leaderboard there. Okay, I think hopefully I've got some pictures coming up somewhere. See if they work. Okay, there we go. What's the priority for this patient? Good. I like it. So good quality CPR is obviously important, but in a VF arrest, the sooner we get a shock in, the better. So very well done, folks. That's good. So that's ventricular fibrillation, early shock advised. You've got that. Dorota, fastest, very well done. Perfect. And another one. Question 9, looking at your screens. So your patient has ROSC, presents with that ECG. What's going on? STEMI, inferior STEMI, anterior STEMI, or left bundle branch floor? Very good. Doesn't let me bring the picture up again, but your ST elevation was in 2-3 and AVF. Okay, there your inferior leads. So that is absolutely diagnostic of an inferior STEMI. So very good, excellent. Let's see who got that right. Do an ECG checkup. If you're not sure about ECGs, have a look at the last couple of webinars. Very good. I think Chris was quickest there again. Blimey, he's steaming on there. Excellent. And the last question, folks. I would say all to play for, but the patient on the way to hospital presents with this rhythm. What should you do first? Start CPR, check for a pulse, shock, or tell the cath lab. Very good, fantastic. VT. Got to check that it's pulseless. All right, technically we're not allowed to shock a pulse VT. Well, there's no technically about it, you're not. But it's one of these things. All right, so you check for a pulse with VT. If there's no pulse, deliver a shock. All right, fantastic. Let's see who got that right. Well done. Oh, we have a winner. Chris, fantastic, very well done. As long as you realise that on your certificate, if you do come and join us for a face-to-face course, I'm going to put Chris Rear, regardless of your surname, and sing Driving Home for Christmas for the rest of the day. So, very well done, Chris. If you don't mind just dropping us an email with your real name, and we'll get you a discount code. Then we, of course, hope to see you out there. It's a really good score. Well done, folks. Hopefully that's been enjoyable. Let's go back to this. So Charlotte's just popped in the chat. There's links to leave us reviews. There's links to claim your free CPD certificate for tonight. So do take advantage of that if you would like to. Chris Rice, is that it? Can't you change it? Brilliant. So fantastic. Well done. We'll be back next Wednesday, 7:30 again. And we'll be doing the safe administration of life-saving medications kind of update, the SARM medications update. There's been a few changes since last year. So hopefully you've all enjoyed tonight. ILS is a really important subject. If any of the stuff we talked about tonight, you think, you know what, I'm rusty with that, I'd like to come and practice it. You know, obviously we're not just trying to make money. We would like to genuinely see you down and meet all the faces behind the screens that sooner or later, I'm sure most of you have your FREC 4s by the looks of things. So come and see us, and in Aylesbury, do your ILS with us, and we'll practice all this stuff face to face. But of course, if you can't get to us, then do just make sure you do some CPD around any of the subjects you found difficult tonight, just because it's one of those things you need to know it off your head when the proverbial hits the fan. So we'll leave you to enjoy the rest of your evening. Thank you ever so much for coming. It's always great to see a nice turnout. So we hope to see as many of you as possible at 7:30 next Wednesday. If you joined in halfway through and want to catch up, it will be on our YouTube channel within a couple of days. Free certificates, as I say, Charlotte's put the link in the chat. And we do also really appreciate it when people leave us reviews. It does help new customers find us, and it helps us keep the webinars free. If we're bringing in customers for the business, then we're allowed to carry on doing these free of charge. It's been great to see you all. Thanks ever so much. I'm glad that you've all found it useful. Any questions, drop them in the chat now, or drop me an email at webinars, and we will get back to you as soon as possible. See you next week, folks. But I'll take questions if there are any. Just scroll back, make sure there aren't any. Fantastic. Oh, there you go. Charlotte's put the link to register for next week as well. That's handy. Thank you. So I'm not seeing any questions come in. As I say, if you do think of something later, then feel free to drop us an email, and we'll get back to you. Hopefully see you next week. In that case, I'll stop the recording.